Thank you very much. I'm standing in for Dr. Philip Crowley. He's a much younger version than me, and I will do my best to represent what he wanted to say today. John, you really worried me when he was going to give a history lesson, because I thought he was going to talk about me. Because I have really think at this stage I'm probably the last one of the history of the health service in Ireland. And I started as a lowly occupational therapist in the 1970s. Most of my colleagues are retired. I'm still here. I'm an eternal optimist. I guess that might explain it. But I remember when I went to Canada in the early 70s, well, mid-70s, and we were paid by an insurance company. So the insurers wanted to charge the hospitals for our services. And one of the ways they did it was how to measure the data and the outputs of our service. So we had to go to McMaster University and McGill University, and we did a lot of courses on, they were working out at that time how to measure the outputs and what was the added on value of an occupational therapist and others. They used us at the time. So I kind of started this process way back then. I picked it up and dropped it lots of times in the meantime. But just to say, that's kind of the background. Where I'm coming from today is many iterations later of the HSE. And okay, everybody says the HSE, sure, you're not going to be there. No, we'll be rebranded and come back as something else. I'm around long enough to know I'm on the same bus that goes around and round. And we get new drivers and new passengers. And we like to forget what happened before, and we like to reinvent it all again. But actually, I would hope someday somebody will start building on the knowledge that we already have. We started working, all of you here probably are working on standards and have been for years. All of you have worked with your standards of practice for years. Don't throw it out. Use it, because that's where you're going to start. You're going to stand on the shoulders of the others that came before you and work on it from there. There's nothing new in anything that's going to be presented today or is going to be given to you in the line of standards. Just keep working on what you always did. And really, I suppose that's the kind of theme I'm going to present to you today. We're inside the HSE. So we're the helpers in the HSE around quality and patient safety, and we're available to all of you. The National Director for the Quality Patient Safety Director, as I said, is Dr. Philip Crowley, and I'm sure many of you know him. We're responsible for the whole area of quality improvement for patient safety within the health service. Okay, we're in the tent. We look at the whole area of risk management, service user involvement and advocacy, big part of our work at the moment, and I'm absolutely committed to, we don't know about the service and the pathway unless you include the patient, and Mary had talked about that. The management of serious adverse incidents to ensure that we're actually robustly managing those right throughout the organisation. National audit, and that's national clinical audit, I'm sure you're aware of. Lots and lots of different patient safety programmes, clinical governance, and the whole area of clinical directors. And some of you may have already met Maureen Flynn, who's working on the whole area of clinical governance. Again, she would be the first one to say, this is new. We're actually redoing it and putting it out again. And the directorate is the relationship link between HIQA IMC, SCA and HCAI. I'm just continuing on that, and of course I have to get a ploy in for myself. People were selling their areas earlier. I'm directing at this stage because in the stage of my life I'm at the so what bit. We're doing so much, is it making any difference at all? And I'm now the checker of that. I'm going out to see, and it's part of a quality improvement process, and it informs decision making. So we go out and we provide level 2 assurance to address the assurance gap at corporate governance level. Explain what that means. A few years ago, I was looking at the CEO who was signing the Statement of Internal Control. Healthcare organisation, Professor Drum, who's a consultant, he's signing the Statement of Internal Control as he's required by law, and yet there is no assurance whatsoever for the business, which was healthcare. It was all finance. So I said to him, how can you sign that? I was head of quality and risk at the time. I said, how can you sign that when you actually have no assurance whatsoever for the whole business, which is healthcare? And he looked at me. I was not very popular with Professor Drum. I was always giving him bad news. But he looked at me and said, what does that mean? So the whole thing is we have internal audit for finance, for fraud, for HR, but we had nothing that checked on the business, which was clinical and social services and primary care and all of the rest of them. So then I went to the board, and the board said to me, well, you've been giving us lots of information. How do you know it's true? I don't. Self-assessment. Anyone who gives me information, they're self-assessing themselves. Nobody is checking it. And we were waiting kind of with our hands, sitting on our hands saying, well, the external regulator will come in and check it. We can't do that. We have to get our own house in order first. So I then got the job of developing and establishing a quality assurance process, which is an audit team of people who now go and check the self-assessment. And we do that by auditing, and we bring it back and we make recommendations. The recommendations are about quality improvement. But we're now filling the gap, which was never there before, in the corporate governance area for the quality and clinical care services. It also is given for the very first time, which is very hard, as you know, us, the clinical and social services, a voice at the corporate governance table. They just talked about finance. Now there is actually something coming back, because I report to the CEO and the board on the whole area, this whole area, and people in the front line are getting a voice at that level. I think I've gone through the whole piece there. The other pieces, the focus we're doing now is on the leadership and governance. And I think all of you will agree that if we don't get that piece right, the rest won't work. This is the whole clinical and corporate governance piece, and again, it's that integration of all of the governance is together. And we spent a lot of time doing this, because if we don't get equal airtime, if we are not as important as the financial area, my experience all over the years is we have no voice. We don't matter. Maureen Flynn has done a lot, and I have her contact details. She's done a lot of work on the whole area of clinical governance. She's brought a really nice, neat handbooks on it. And actually, I've lived through many iterations of clinical governance that sort of live for a while and then die, as most things do. This is a nice piece that I think you'll find really useful. I'm only introducing you to these because they're there and they're available. We'll send them to you, and they're really straightforward and easy. And I know some of you have already been involved in piloting all of these. All of these have been piloted with the services and redone, and this is what we've come up with at the end. So that's just a version of how to use those prompts. They're very practical and straightforward. These are the messages now coming from my leader, Philip, that are directly related to the primary care people, yourselves here. And I suppose the context in which we're working is very much around primary care teams, acute hospital networks, the new directorates, the chronic disease challenge, major financial challenges, the national standards, and the various other policies there. That's our context, that's our reality, and we're internal managing those at the moment. Philip has said that there is a lot of quality in the Irish general practice piece, and I know from the information and from the auditing we have been doing, we have been finding that. So going back to my starting point, build on what you're already doing. Do not throw out what you're already doing, because this is about that. This is about building that. And I'll discuss that a little bit further as we go on. The challenges for you at the moment is that whole piece, and I think the previous speakers have spoken about them. It's the information piece. It's the isolation. It's the use of guidelines and risk management tools, the out-of-hours cover and the patient information. We're starting to do an audit at the moment about that handover piece, and there's some very significant problems arising, which we hope in our recommendations will be able to assist at. The medication reconciliation and prescription errors, the minority groups and disability access, and the lack of critical incident near-miss review. And I think, the learning is around the near-miss piece, and we need to be picking those up. We need to be helping you to manage those. Further options to improve quality involve the local community and the patients. And again, this is the voice of the patient, which I know all of you hear because they talk to you. The real PCT development and involving pharmacy. And I think the big message in a number of this was, what is a multidisciplinary team for you? And are they really there? And how are they managed? And again, I'd like to talk to you a little bit about that before I finish. And listening down there, and I actually don't really want to read them for you, but I think that that's the kind of issues and the context for you and the options that we may be able to help you with. Again, you are able to, again, building on what you already have, you're able to build on this. You already have people in place and you're already working on it. And I think there you have challenges in that, but again, it's working together to improve the quality through training, evidence use, and acceptable performance measures. And again, they're all of the internal things we're working on with you with various people. Going back to my starting points again is we start building on what we've already done and what we are already doing. And this is about our everyday job and the business we're already engaged in. My experience to date would suggest to me, and what we're continually finding still, is the whole governance and leadership piece. Who is accountable and responsible, and to whom for what? We cannot have safety and we cannot have quality unless we're very clear about that. And most of the areas that we are finding, and indeed most of the critical review external reports that have been done, they're finding that there's a breakdown around the governance and leadership. And in my view, if you want to know where to start, I suggest that you start there. That you start looking at that, and you start with yourself. To whom am I accountable? Where is the governance here, and where is the leadership? Because that's where the quality piece starts. The other thing, who is the team? And is it really a multidisciplinary team? We use that word all over the place. I remember in college, and the multidisciplinary team was this wonderful thing we all had to achieve. When I went in to start working, I spent probably the rest of my life trying to establish a multidisciplinary team that truly had the patient at the centre and was not about tribalism, each one of us trying to build our own empire. If we don't have a multidisciplinary team, all of the people there who have voice and are involved in the decision making with the leadership and a governance in place, we can't have quality and safety. We can help you with that also. This isn't about standards. It's not just about standards. It's about a change of behaviour. We have seen so many standards coming and going. There's so many out there. But yet, unless we change our own behaviours, we actually won't see anything different. We can measure everything we like, but if we still continue to behave in the same way as we always behaved, and if that was not, when we looked at it seriously, the way we should be doing it, that it's not our standard of practice, then it's not going to change anything. It's not going to make it safer, and for patients, it's not going to achieve quality. This is just something that I think I like to think about for myself, because most of the time in my working life, I couldn't wait for others to come and tell me. I've had to go and find and do myself. And I really think change comes from small initiatives with work. Initiatives, when initiated, become fashion. We cannot wait for great visions from great people, and we must light our own fires in the darkness. That sounds very pat, but actually it really means that you start with yourself. You start building it yourself, and you start working on the small areas. I don't know who the great fires are anymore, really. And maybe they're the external people, maybe they are the standard bearers and so on. But we got to start today with ourselves, with our own standard of practice. If we can help you, we're there. We're internal and we're available. And Philip is always there to talk to you. I'm involved in the whole assurance piece. Maureen Flynn is around the clinical governance piece, and Mary Brown is now rolling out the national standards. Thank you very much.